This time, however, who knows? Who knows? We don't have to worry about the ending of that. I don't think he produces them anymore. And who wants to watch a 4-hour video of someone sitting in a room and staring and smiling? Anyways, yes, says the lecturer, which is basically what I do, except I just talk at the same time and feed information. Anyways, this week is neurolinguistics, and this is a pretty short week. There's not much to say. We're just going to talk basically a little bit about brain stuff. We could have done a lot of really heavy biology this week in terms of brain lobes and what everything does, and really get into the nitty gritty of the brain. But um, I'm trying to keep this course very not memorizing and just more so about uh, conceptual stuff and more real life applications as much as I can. So we're going to focus more just on neurological language disorders and reading disorders and speech disorders. So it's going to be a pretty short week. We're still going to cover a little bit of the brain stuff so we know how the brain works and what the important lobes are and what gets damaged to cause some of these issues. But the focus is going to be on the actual problems themselves this week. So, uh, I guess normally I start by talking about last week's practice exercises. So why don't I do that? Um, Overall, there weren't really any issues to talk about. I did give one question the full points for everybody, and that was the Mandarin question about the word friendship. So there was the question that was, how would a Mandarin speaker pronounce the word friendship when they only allow certain syllable structures? Sorry, the page is loading right now, so I'm trying to stall while it loads. Window capture the problem. There we go. There I am. As I scroll down, this one. So they either add after every coda to make a new syllable. So if I just zoom in a little bit more here, this one was enticing to people. However, after the word friend or after the syllable friend, we would need another schwa there. So it would have to be like friendship. So this was enticing. And then this one, friendship. If we delete the entire coda, the N shouldn't really be there. So fresh should be the best answer. But because Mandarin allows N and ng in a coda position, the N could still stay there. So according to the strategies, it wasn't entirely clear that the N could still stay there. But in lecture, it was pointed out that the N could still stay in a word like sent. So because that wasn't completely clear from the question, I just gave the full points to everyone because the best possible answer wasn't actually there in the question. But friendship was the best answer out of the choices, and fresh without the N would have been the best answer according to just the strategy above. So if a question is like this on the test, I'll make sure it's much more clear and not assume background knowledge from the lecture about N and ng being allowed to stay. The rest of the questions were done fairly well. Nothing else was really below 80%, except for, what was it? This was one just for people choosing extra ones. So these are English words like the long sounding vowels. So I tried to put long sounding like E and oo. So cut is kit, lick. These are not pronounced keet and coot. So wheat and shoot are your answers there. What was the other one here? Based on morphemes in the sentence below, which sentence would be spoken by the most developed speaking child? So if you looked at the morpheme acquisition chart, you would have found that is eating, was the last morpheme that was acquired by a child. So the is, the auxiliary is, that redundant is for eating, is the last thing acquired. So this is the most developed child would acquire that, while the possessive morpheme, mummies, uh, dogs, and plural, these are acquired a little bit earlier than the other ones. And that was it for the questions that were like under 80%. Were there any questions in this list that you want me to talk about that I didn't just cover here, so other than those two? I mean, overall, the language acquisition questions I thought were done pretty well. Okay, if you have any questions about the assignment, you can ask at the end of today's lecture, and there'll also be time at the end of next week's lecture to ask about those, since the assignment will be due midnight at the end of next week, and the practice exercise will be due at noon next week, as always. So neurolinguistics. Neurolinguistics is about the brain. So when we talked about language acquisition, we're still talking about brain stuff, but more about the behavior of a child. This we're actually diving into the brain, and we're talking about behavioral problems and language problems that arise because of issues directly involved with the brain. So if you've taken anything in psychology, you probably know a little bit about the brain. If you haven't taken anything in psychology or biology, you might not know that much, but we'll start with the basics. So your brain is divided into two hemispheres, a left hemisphere and a right hemisphere. So we say that the brain is lateralized. And the way that the brain works is actually quite interesting. So the right hemisphere of your brain controls the left half of your body. So the fact that my right hand is moving is actually being controlled by the left hemisphere of my brain. So we say this is what's called a contralateral brain function. So that's this word here, contralateral. So everything on the right side of my body is controlled by the left hemisphere in my brain. So if there were to be damage in the left hemisphere of my brain, you would see problems with the right side of my body. While if there was damage to, sorry, everything's mirrored, so I might get my hand movements messed up on my webcam sometimes. So if there was damage on the right hemisphere of my brain here, then we would see issues with the left side of my body. Okay, so basically, the hemisphere in your brain controls the opposite side of the body. And each hemisphere in your brain is mainly responsible for different functions, uh, different cognitive functions. So this is a little simplified. We could say that this is like, I mean, typically you would say that one hemisphere controls a particular function if we want to be really simple, but we would say for this purpose that like language is mainly controlled by one hemisphere. And for instance, like attention is mainly controlled by one hemisphere. Music is mainly in one hemisphere, and so on. So there's a little story at the bottom here. So like a musician has a mild stroke in his right hemisphere. So um, his right hemisphere is damaged by a stroke. He can still do things. He can still teach music and play music, but he can't recognize faces. So because his right hemisphere is damaged, he's lost pattern recognition, but he can still play music. So even though one hemisphere is damaged, he's lost some abilities, but not all. So this is how we get the fact that certain aspects certain abilities are reside in just one hemisphere, or are mainly controlled in one hemisphere and not in both. Because if one side of the brain is damaged, we don't lose everything. Sorry, we don't lose everything. We just lose some things. So here's like a little list of what's controlled by each hemisphere. And this is a really simple, really simplified picture of what's happening here. Um, like if you do go on to further psychology and neuroscience, don't look back at this and think, okay, this is a 100% accurate picture of what's going on, because it's not. This is incredibly simplified. But typically, uh, things that are related to language, logic, analysis, the left side, the left hemisphere is like your logical brain. And the right hemisphere, your right brain, is your creative, musical, imaginative side. It's the side for patterns, the creativity, all that kind of stuff. So I'm sure you've seen many pictures online where the left side is like a computer and the right side is like this explosion of art and color. It's a very common image. So left, right brain image. Let's see if I can just find one on Google Images right now. Oh, there we go. It's beautiful. Look at that. The left side of the hemisphere is all computery, and then the right hemisphere is all flowery and artistic. This is you'll see many of these online, and this is an oversimplified picture of the brain, but this is how we can start for our base. So, of course, this isn't how everybody works. So our focus is really just language. This is what we care about. So most people have language in their left hemisphere. But if you're left-handed, there's not a great chance, but roughly a third of you, if you're left-handed, will actually have language dominantly in your right hemisphere. So that's kind of interesting. If you're left-handed, how can you tell? Well, you'll have to have a stroke or have a brain lesion or something before you can actually tell. Or you can, get hooked up to an experiment and have things probed to see where your activity is. That's probably a better way without long-lasting damage to have that checked. Well, yeah, about a third of left-handed people have language in their right hemisphere. And if you do have brain damage to your left hemisphere and language is impaired, for the most part, your right hemisphere can pick things up and you can relearn language. So it's not a lost cause. The hemispheres do interact with each other. They interact with, let's make this larger. Sorry, when I go between courses, the slides are different sizes, so my text changes. Hemispheres interact through what's called the corpus callosum. I'm probably spelling this wrong. I always get the letters mixed up here. Through the corpus callosum. So when the left side is damaged, the other side can pick it up. So when the left side is damaged, when language is damaged over here and you need language, the right side can pick up language when necessary. Okay. So most of the damage that we're talking about today is going to be occurring in the left hemisphere. But of course, if you're left-handed, there's a good chance that all the damage to the right hemisphere could do the same thing. So there's 4 lobes in the brain. And 4 lobes, left hemisphere, right hemisphere, they're the same lobes. We have a frontal lobe. So the frontal lobe is the lobe that accounts for what makes humans very intelligent, This is where our reasoning ability comes from, our fine-tuned motor control, our emotional regulation, and particular language. So our syntactic ability, and we'll talk a little bit more about this with Broca's area. So this is just a general overview. We have the parietal lobe. So this lobe doesn't really concern us too much. This is just how we process information. So, um, I'm trying to, how do I do this with the camera? So when I turn my head like this, so I'm facing to the left on the camera, this is the frontal lobe. This is where your forehead is. The parietal lobe is a little bit further back. This is where information is being processed from the body. So when I hear things, when I get touched, when I get hurt, that information is coming through. Um, the back of the head, a little bit above the neck, this is called the occipital lobe. This is where visual information is coming in. And then finally, a little bit around here is what's called the temporal lobe. So right below the frontal lobe. And this is where hearing, memory, emotion, and your semantic information is coming in. So this is where language, or what's called Wernicke's area, is. So if I just give some more information here. So this is your syntax, your grammar, specifically with language, and this is your semantics or meaning. You don't have to memorize the brain structure in this course, but if you're in a psych course where you do have to, I always remember this as FPOT. I don't know what acronym you give it, but FPOT, from the front to the back, clockwise, is something that I always used. So we're really just focusing on the frontal lobe and the temporal lobe. The parietal lobe and occipital lobe isn't really too important for us. So what neurolinguistics studies is the relationship between what happens in the brain and what happens with language. So when certain things are damaged in the brain, how does that affect language? Okay, so how this first started was when people got injured, they noticed that there were language problems. And we're not talking about things like speech problems. Speech problems and language problems are different. So let me just write this out. Speech problems are not the same as language problems. So when we say things like speech problems, we might mean speech impediments, things like lisps. So lisps are speech problems. Stuttering is a speech problem, but language problems are different. Language problems are like inability to form sentences, inability to acquire grammar, or to choose words. These are much more severe, because this is like being unable to go into your brain, into the dictionary in your brain and pick out a word, inability to go into your brain and acquire the grammar. While a lisp is like a problem with your tongue, stuttering is a problem with the muscles in your mouth, trying to get words out. So we're not looking at speech problems here. Those are things that can be fixed with muscular training. We're talking about actual language issues, things that are neurological in nature that can't just be fixed with some simple training. So two things that we're really going to talk about at the end in more detail were discovered by Paul Broca and Carl Wernicke. It's written with a W. It's pronounced more like a V, so Wernicke. Two things called aphasia. So this is like language loss. So Paul Broca discovered that lesions or damage in a part of the brain resulted in the loss of syntactic ability, so the inability to form sentences. And Wernicke found that lesions in another part of the brain resulted in the loss of semantic ability. So uh, these resulted in two very interesting types of sentence production, and we'll see those in action a little bit later. But these two were sort of the start of modern neurolinguistics. And what's interesting about these types of patients is that, and we'll see how they produce sentences, but even though their sentence production is not great, their understanding in certain aspects is still generally okay. So another thing from this lecture that we can take away is that even though patients, when they speak, they might not be able to produce sentences that are okay, we can still talk to them as if they're normal, regular speaking people, because they can understand us just fine. They just can't produce things. Question: are there examples where individuals endure brain trauma and come out speaking a different language for real? Most of the people doing that are faking it, because you have to understand the language beforehand in order to speak it. You can't just magically learn a language, because all language is arbitrary. So you have to have input, and you have to actually know the language before you can just speak it. You'll never be able to just magically understand a language overnight. You have to actually have it internalized and learned. Unless they got a lot of input as a baby and then they just somehow have it stored but not accessible. But I don't think there's any examples of that. Um, most of the cases you see in the media where people do speak a second language or have claimed to forgotten how to speak a language, most of them have been proven to be faking it for media attention. I think there was a case like 10 years ago where that happened. Um, I remember a news story. I don't remember the details, but I remember on YouTube it was a big deal. Okay. So, I mean, before we start talking about all these details, let's talk about some of the ways that we can actually get information from our brains. Because at some point in your life, I mean, you'll probably do one of these things. So we'll talk about PETs, fMRIs, and MEGs. There are other things we can talk about, like MRIs, CT scans, and so on. But these three types of tests are really the best for language. Okay, so we'll start with a PET. So this is the positron emission tomography. Okay, so all of these tests are, well, not all of these tests. The PET in particular is really good at figuring out what the brain is doing in real time. So what happens with the PET, and this is a really invasive test, so this isn't done too often. And what I mean by invasive is that they inject this radioactive tracer and glucose into your brain, so that way they they can pick this up, so they can trace it as it goes through your brain. They have you do a task, like some sort of language task. So that way they can see what's happening. Because as you do tasks, your brain is using glucose. Your brain sugar is going to the areas that are activated. And what's happening is this tracer is going along with it. So when you're doing a task, the areas that are being activated are being shown, as you can see in the colors here. High activity is being shown in red. So the tracer is being picked up, and they can monitor in real time which areas are being activated. Okay. So, I mean, this is very this is very invasive. Um, it's very invasive because you're actually injecting a person with something like directly into the brain. Um, it's none of these techniques are cheap, so we say it's quite expensive, but fMRIs and MEGs are just as expensive. Although we can see exactly where it is in the brain, it's actually not that great at telling us when things are being activated. So I forget exactly how quickly it updates, but some of these brain tests can activate and tell us how things are happening millisecond by millisecond. This is not that fast. So PETs are not really the best test we can use to see where brain activity is occurring, but it is one of the earlier ones. So I chose this picture just because we can see where things are happening, like in the brain. So when you hear words, you can see some activity in the temporal lobe. So this is more like center low. When you see words, this is back in the visual center, the occipital lobe. When you think about words, you can see this in your frontal lobe. Um, and when you speak words, again, more like in the frontal lobe and a little bit, not so much in your parietal lobe, but more front center. Okay, so I mean, we don't really use PETs that much. fMRIs are a little bit more common. fMRIs are not that invasive. If you've ever had an MRI, they use the same machine as an fMRI. So let me show you the fMRI machine. If you're claustrophobic, this is a horrible, horrible thing for you. I had my first MRI 6 months ago. I did not think I was claustrophobic until I had the fMRI. Sorry, until I had the MRI, and then I learned I was claustrophobic in the middle of it. So basically, you're put in this little headrest. Uh, sorry, why did I click on that? You put in this thing. They put your body inside this tube. It's very tight and small, and then everything shakes. It's very loud, and you're in there for like 30 minutes as they take scans of your brain. But it's not invasive. They're not injecting you with anything. They're just monitoring the activity. So it's less invasive, but it's incredibly expensive. You cannot just have an MRI machine. Usually these are put in hospitals. So if you want to do a test with these, you need to be partnered with a hospital or a private clinic, and they're usually in high demand. So if you do want to do a test with these, you cannot just book one for the same day typically. You normally have to book these weeks or months in advance. And how these work is these monitor the iron in your blood flow. So you don't have to be injected with anything. This just uses stuff that's already in your brain. So it's the same thing. Participants usually perform some type of task. So the nice thing about fMRIs is even though you're in the machine, you can still have you can't usually have metal in you. So if you have any metal, you have to take it out. But there's usually speakers inside the fMRI, so they can have you do something with language, either speaking or listening or thinking about something. So that's a simple task that you can do. And then they can monitor how the iron is moving around your brain to see what's being activated. They can see precisely what's happening and where it's happening. Yeah, it's the same machine as an fMRI as an MRI. Well, I should say it's it's the same looking machine. I don't know if it's exactly the same machine. It looks very similar. It's the same design. Um, it's magnetic. It's functional magnetic resonance imaging compared to magnetic resonance imaging, but I'm sure it's very similar. So I shouldn't say it's exactly the same machine, but it's uh it's functionally yeah, it's the same. It's essentially the same. The scans are different. Okay. Um, what else was there about fMRIs? Yeah, great spatial resolution. If you've ever seen an MRI scan or an fMRI scan, which you can see an fMRI scan in the top right corner, if you've ever seen MRI scans too, which I'll try to pull up, just again, another image. Um, what these ones do is they'll go scan by scan. So they'll take like uh, uh, 60 60 images with an MRI, and they'll go down your brain piece by piece. So they can locate things very precisely. The only downside is that they typically can't see precisely when things are happening, so they're not very good at seeing like instantaneous changes, but they can see precisely where things are. So again, very good spatial resolution, so where it is in the brain, but not very good temporal resolution, so precisely when it's happening. So MRI scans are anatomical, where fMRIs are metabolic or metabolic. Yeah. Yeah. So this is more about like where the activity is happening rather than what's wrong with the structure. Okay. So PET and fMRI, if we're going to do one or the other, PET is a lot more accessible, but fMRI has a lot more advantages in that it's a lot less invasive. The problem is it's a lot more expensive and it's not really accessible. But an fMRI is going to be preferred. However, the best of both worlds, and really the best test that you could do with a brain, is going to be an MEG. So this is here's the word, magnetoencephalography. Um, uh, enceph the encephalus means head. That's sort of the root here. So that's what the encephalus means. So it's a magnet head scan essentially. And this is a lot less invasive than an MRI. So if you have claustrophobia, you do not need to worry about an MEG. This just uses changes in magnetic fields. So it's incredibly advanced technology. It's very cool, but there's a lot of problems with this. First of all, again, incredibly expensive. Two, not only is it expensive, but you have to do a lot in terms of where the machine is placed. Because it uses changes in magnetic fields, you need to make sure that there's no outside interference for the magnets, which means that when you set this up, there needs to be a lot of work that goes into the setup to make sure that there are no problems. Um, so you can't just buy this for a university and put this in a lab and say, okay, we're good to go. Typically, you're only going to find these again in hospitals or in labs that are like very, very well funded. But the main advantage of MEGs is that not only is their spatial resolution amazing, meaning that they can pinpoint exactly where things are in the brain, they have amazing temporal resolution, which fMRIs and PETs don't. And what we mean by great temporal resolution is that they can show you activity changing millisecond by millisecond, which means that um, in your brain, you can actually see the brain activity live. Like while you're doing the activity, you can see what's happening in your brain as you're doing it. And that's incredible. So, like, if you want to test to see if you have brain disorders and where you have problems, and if your blood is, or sorry, not if your blood is flowing, but if things are behaving as they should be behaving, an MEG is the test you want to be using. Just wondering which one is the cheapest. The PET will be the cheapest out of the three. But it's very, very invasive, and most people will not opt for it. fMRIs will be cheap too, but if you need one through the BC government, the wait list will be very, very long. You'll have to wait quite a few months for that. After that's you'll have quite a few month wait after the wait list for the specialist. So probably about a year and a half just to even get an fMRI when you think you might need one. That's not a jab at the health system. That's just how it is, unless you pay privately, in which case you're looking to spend quite a bit of money. So, I mean, these are how we can get in the brain. These are the modern techniques we use. So if you actually do something, you're probably looking at an fMRI or an MEG for anything serious. If it is extremely serious, of course, they'll rush you in. Okay, are there any questions about these three? Okay. Well then, here's a question. When you talk to your friend on the phone, do you normally put the phone on your left ear or your right ear? I have a poll, so let's do the poll. That should be up. Why do I have yes or no? Hold on a second. It doesn't make any sense. Yes or no? What is happening? Okay, hold on. Ear. It was a 50-50 split between yes and no. Okay. Let's do this the right way. Oh my God. So that's how my day is going. How are your days going? Okay, yeah, 89% of you have answered. That's good of it. That's good. Okay, most of you put it on your right ear. Some of you put it on your lefts. I put it on my left ear, so I'm putting an extra tick onto that. That's not actually what I was, well, it's what I was expecting. So we have this thing called a dichotic listening task. And in a dichotic listening task, uh, we have headphones on. And when headphones are on, uh, we feed in input into both earphones, different inputs. So they can be words, sentences, numbers, sounds, whatever. And we play different things into each ear. And after usually a sentence or 3 words or 3 sounds, we ask the participant to repeat what they hear. And usually what happens is participants repeat back the thing that they hear in the right ear better than what they hear back in the left ear. So, can any of you guess why the right ear is heard better than the left ear? Because it's the left hemisphere. Because language is primarily in the left hemisphere. That's why. If you're right-handed, then left brain is for language. And because the left brain controls the right side of the body, the right ear has an advantage. So I'm left-handed. I might be one of the people who has language processing in the right side. So maybe that's why I do everything with my left ear. I don't know. Maybe I am a right, maybe my language is in the left hemisphere. Maybe, I don't know. But I'm a left phone person. Um, I don't know. If you're not convinced of this, there is a link here that you can do by yourself. You can do the dichotic listening task and you can hear things with your left ear and right ear and you can repeat back. But yeah, this is a little dichotic listening task you can do. So you can put the headphones on, you'll hear things in your left ear and your right ear, and you can see which one is more accurate. So here's a little practice. This is the right ear, this is the left ear. If someone hears the horse galloped across the field in his right ear and President Lincoln often read by the light of the fire in the left ear, which is this? Uh, which sentence is this person likely going to say back? Assuming this person is a right-handed individual. Ah, the horse. The horses galloped across the field. Now, what if the participant is a left-handed person with language in their right hemisphere? Yes, okay. Then it would be Lincoln. Most likely Lincoln. Most likely Lincoln. Thought I'd throw that in there just because it wasn't on the slide, but a good little exercise to do. So yeah, that's the concept behind it. The right ear advantage exists because most people have the language part in their left hemisphere of their brain. Okay, good. So that's one of the earlier tasks too. Is there a possibility of not having a dominant ear? Most people do have a dominant ear, just because language is primarily in one hemisphere or the other. Perhaps if someone has had damage in one side and then language is relearned on the other side, maybe there is an ear that is not dominant, but I'm not sure if there are any studies where that has been done. And if there are, I'm not sure of the results. I'm not aware of any individual where there's like um, equal distribution of language in the left and right hemispheres. If that is a thing, I would imagine that would be fairly unusual. Okay, this is something else that you might find actually quite interesting. And this is a question that I always had, well, I had when I first heard of this stuff, and I was always amazed that there was an answer to this so quickly too. What happens if the hemispheres can't interact with each other? So I said earlier there was this thing that connects the two hemispheres called the corpus callosum. And we can actually see it here. So sorry if this does make you a little squeamish, but this is a picture of a real brain. Um, and this is the corpus callosum that connects the two hemispheres. So we can actually see this. Um, okay, so what happens if this is cut in the middle? So we just take a line and we just chop this in half and well, not completely in half. The brain still has to function, but what if the left and right hemispheres can no longer communicate with each other? Okay. Without a corpus callosum, we call these patients split brain patients. Okay. And from this, it was found that the language side of the brain, the left brain, is responsible for language, responsible for verbal tasks. So that's really how it was pinpointed that the left side was for language. Okay, so here's something interesting that comes out of it. So this is the key ring experiment here. So a patient sees two words on a screen. Yes, this was actually effective for treating epilepsy. Interesting, it actually was. Um, so a patient sees two words on a screen. He sees one word in his left visual field, so key on the left visual field, and ring on the right visual field. Okay, and what the patient is told to do is the patient is told to pick up the object of the word that he sees, and he's told to say the word that he sees out loud. Okay, so remember the left hemisphere and the right hemisphere cannot interact. But one hemisphere is for language, and one hemisphere, what we'll do the other stuff. But we're really just focusing on the language aspect. So his left hand is picking up the key. So he's holding the key. But his left hemisphere is for verbal tasks. So what word do you think he's going to say? He's picking up the key, and he's supposed to say the word that he sees, but he's also supposed to pick up the object of the word that he sees. So he sees key, so he picks up key, but what does he say? Yeah. Even though he sees key and he picks up key, he says ring. So he can feel key in his hand. And he's picking up he sees the word key and he picks up the object that he sees. But he still says a different word. So this is an incredibly interesting experiment. Because the patient, the brain, the two hemispheres just aren't interacting with each other. Like the patient is doing both tasks correctly in a sense. He sees a word and he picks up the word, the key in the case. And then he also says a word, ring. So he's seeing both words. And he's doing the same task, but he has different outputs. One different output for speaking and one different output for physical actions. So the muscles are behaving different than the voice, than the speaking. Um, so it's, I don't know. I think the historical aspect of neurolinguistics is really interesting because a lot of what we know about language actually came from patients with disorders, with problems, and experiments with those. The reason why we know where language is and how this works is because of patients with split brains without corpus callosums, people who had epilepsy, um, who were then saying, okay, now we have, we cut this corpus callosum to fix your problem with epilepsy, and now suddenly you're having issues with language. Okay. You're also having issues with other things that aren't language related. But let's run some experiments and see what are happening. And here we have it. So yeah, because again, language is a left hemisphere issue. Speech is on this side. It's just reporting what the right eye can see. Because the left side controls the right side of the body, the right eye sees ring. So sorry if I didn't make that explicitly clear before. The right eye sees ring, so the left side of the body does what the right eye sees, which is ring. While the right side is doing the movement for the left hand, which the left eye sees key. So the left eye sees key, so the left hand picks up key because that's what the right side of the brain is telling it to do. But the right side of the brain and the left side of the brain are not interacting. Okay, are there any questions about this split brain experiment? Yeah, so the left side sees key and the left hand picks up key. Yeah, that's exactly what's happening. the left side sees key and the left hand picks up key, but he's not saying key because the left hemisphere is responsible for verbal tasks and the left hemisphere works contralaterally. So the left hemisphere is for the right side of the body. So the key goes to the left eye, and the left eye interacts with the right hemisphere. But the right hemisphere has to talk to the left hemisphere in order for him to say key. But the right hemisphere can't interact with the left hemisphere because the corpus callosum is split. So the right hemisphere can't tell the left hemisphere to say key. So the left hemisphere doesn't know that key is there to be said. So key to left eye to right hemisphere, and then right hemisphere is like, I need to talk to the left hemisphere. If the patient is a left-handed person, then yeah, then the person might be able to say key. If the person has language in the right side of the brain. But remember, only about a third of left-handed people have language in the right side of the brain. So they still have to be in that special 1/3 of people. If a person had no split brain, then they would probably pick up both a key and a ring and say key ring, or they would just do one or the other. It would be very simple for a person with no split brain to do. They would probably have a different task. They would say, well, which one do I pick up? Because they would have no issues with this. Is the person with the split brain aware that they picked up the wrong item? That's a good question. I don't think they are, because they didn't really pick up the wrong item. It's more so that they said the wrong thing. Because he saw the word key. He knows he saw the word key. It's just that he couldn't speak the word key. He spoke the word ring because that's all that his speech could do. I mean, I guess you could flip it and say vice versa too. Split brain isn't an illness. A split brain is something that you have because your corpus callosum is no longer there. A split brain is something that has to be induced by surgery or by injury. It's not an illness. It's a physical it's a physical lesion or injury or surgical outcome. A split brain is a physical thing. It literally means that your brain is I shouldn't say like physically split, but I mean there's no corpus callosum. The hemispheres cannot interact because it's missing a part of your brain that allows that interaction. Oh, you have a cousin born without one. Yeah, it's a physical lesion. Okay, we're 3:23, so we're going to take a 10-minute break. If you have any questions, we'll come back and answer those, but I just want to make sure we get this 10-minute break in. Okay, so I'll see you in 10 minutes, and we'll put on something a little bit less creepy for this break.
So
Oh, if you're interested in more of that, you can finish that in the link that I just posted in chat after the lecture. There you go. Some cartoon conspiracy theories. And we follow it up with an old pineapple. That was totally unplanned. Anyways, continuing on with some neurological language disorders. So split brains. We're gonna pass on from split brains and just talk more about word production and sentence production issues from now on. So localized damage. And we'll start off by thinking about an issue. If we have, say, some patient that can't produce a word, let's say they look at this picture, and this is a common thing that you would ask a patient to do, is you'd give them a picture of a common object, and you'd say, "What is this?" And sometimes they'd be unable to say this, and this happens with a lot of older people, and when they have Alzheimer's, this happens, and it's usually concerning then, but it's also incredibly concerning when this happens to younger people. So if they're unable to say pineapple, like, why could this happen? Um, maybe they just can't recognize pineapples anymore. That's very scary, but that's not a language issue, so maybe that's not something that linguists are concerned about. But obviously, doctors are going to care a lot about that. Something that linguists would be concerned about is maybe in their mental lexicon. So, uh, mental lexicon, think of this like a brain dictionary. Talk a little bit more about what this means next week with psycholinguistics, but just how words are stored in their brain. Uh, like maybe that's just not in their mental lexicon anymore. Maybe they don't know how to access it, and that's a very abstract concept. But maybe they just can't get it at the moment. Maybe the patient knows what the word is, but they just can't produce it. So it could be a muscular issue. So that's kind of like 3 and 4 together. So these are all the different ways for why someone could not say pineapple. 4 is a muscular problem. 1 is a recognition problem, but 2 and 3 are language related. So the rest of the lecture, we're mostly going to be talking about things like aphasia, dyslexia, and dysgraphia, as well as something called anomia. We're going to go quite a bit into aphasia and dyslexia. So first, aphasia, and we'll come back to it after. We're mainly going to dive into dyslexia. So aphasia is some sort of language breakdown that affects spoken language. So this usually happens because of either brain damage in your frontal lobe or in your temporal lobe. So mainly in your left hemisphere for people who have language in their left hemisphere. Um, and most people do recover from it at some point, but a lot of people don't. And depending on where the damage is, you'll either have troubles with your grammatical productions, your syntactic abilities, or with your understanding and comprehension, or producing words with meaning, so your semantic ability. So that'll be the difference between Broca's aphasia and Wernicke's aphasia, and we'll talk about that at the end. Uh, Dyslexia and dysgraphia aren't about speaking or understanding, but about reading and writing. And we talked in week 3 how reading and writing are a little bit different than language. They're ways of representing language. But neurolinguists are concerned with reading and writing ability too, because in terms of communication, uh, this is important for everyday society. It's difficult to live and survive if you cannot read and write, especially as an adult, if you want to work and keep yourself alive and function. So dyslexia is about reading ability, and dysgraphia is about writing ability. We don't have too much to say about dysgraphia, but just some people cannot write, and the ability to, or the inability to write, is called dysgraphia. Um, Dysgraphia comes from the word grapheme. Grapheme is just sort of like the word orthography. It's just a written character. So a grapheme could be like the letter A, or it could be uh, like the character for woman or something in uh, Japanese or Chinese. Okay. Oh, one interesting point here that again, that I didn't talk about. Um, this point here, which I'll underline here. Uh, this point here. Children up to 11 to 14-year-olds have a better chance, as well as left-handed people and right-handed people with close left-handed relatives, from recovering from aphasia. Now, sorry, I didn't talk about this, but again, the reason why this happens is because left-handed people are more likely to have language in their right hemisphere. And language also has the ability, if the left hemisphere is damaged, to be transferred over to the right hemisphere for recovery. So left-handed people, and being related to left-handed people genetically gives you an advantage for having that transferability. So if you are left-handed or are related to left-handed people, having that transfer from left hemisphere to right hemisphere, left hemisphere for right hemisphere to language, you have an advantage there. What determines whether you're left-handed or right-handed? I think that's just genetics. I don't know the specifics about that. Like, I don't know the specifics about handedness. I think it's just genetics. And if you're like unfortunately born in like the 1960s or 50s or earlier and you went to school, you're probably beaten in elementary school if you were left-handed and then you became right-handed over time. I mean, that's not going to affect how your language was localized, but behaviorally you were probably trained to be right-handed. But your biology is still going to be determined from birth in that case. You used to be left-handed, then I switched to right-handed. Yeah, so I mean, luckily, the fact that you were left-handed at birth is going to determine, or at least have an effect on where your language is localized in your brain. So, if the fact that you were born left-handed is going to give you that 1/3 chance of your language being in your right hemisphere. So what you are now um, isn't going to determine where your language is. It's what you were born as genetically for your handedness. So if you are left-handed or you do have a left-handed relative, um, you do have an advantage when it comes to recovering from any sort of aphasia, which is kind of nice. Anomia is a really interesting neurological language disorder. Anomia is what's the loss of ability to name things, and um, so patients with anomia, they just cannot say things. So like with the pineapple example, and what will happen when an anomic patient sees something like a pineapple is usually they'll just not respond. You'll say, "What is that?" And they'll look at it and they just won't say anything. And if you've ever had an older relative with Alzheimer's or they're aging and you ask them what something is and they don't respond, usually you'll attribute that to them just being old and not hearing or them being slow. But even younger people with anomia, that they'll do this too. It's just it's a consequence of anomia, not of old age. So they'll either stay silent or they'll just give a wrong word. And what happens too is they'll try to repair this problem by being creative and using other words instead. And usually those other words will be problematic and they'll be mistakes. And this is called paralexia. So paralexia, so lexia meaning word, and para meaning other, or like other words. So instead of saying like I want tissues for my nose, they'll say I want some socks for my nose. And the word isn't ever like completely out of left field. And what I mean by out of left field is it's not totally random. There's always some sort of connection between the two usually. So socks for tissues. I mean, socks, there's sort of like the same fabric. You could wipe your nose with a sock. Um, it's not exactly the same as a tissue, but it's not like they're saying, I want some dressers for my nose. Like it's not that different. So anomic patients, they lose their ability to name things. They try to substitute other words instead. Um, and occasionally too, they'll just make like what are called like phonetic errors. So instead of saying things like tissues, they might say something like, I don't know, what's another word that sounds like tissues that's real. There's not many words in English that sound like tissues. Issues. I want some issues, or I want his shoes for my nose. Yeah, his shoes is a good example. Thanks, Justin, and thanks, Nate, for those ones. Um, so they might pick something similar. I have other examples like symphony, sympathy for symphony, or tubber for butter, but I'm trying to give some more examples that aren't just on the slides here. Um, are people with anomia consciously choosing to say similar words? It's not always it's likely not conscious. I mean, they're trying to pick the words from their brain. The problem is that they've lost that ability. So like they're doing their best. They're going into their brain and they're picking the word that they think is the correct word. And it just happens that the words that are being activated are ones that are just similar, or ones that are close. They're not the correct ones. But it's the best that their brain can do. Uh, anomia is almost always accompanied by paralexia. Paralexia is like the recovery strategy. So like they have anomia, they cannot say something, like they cannot name things, but they're trying to name things, and that's where paralexia comes in. Um, you might have some patients that just stop talking altogether because they're embarrassed by it and they're aware that they can't name things, in which case they won't try and they won't have paralexia. But people want to talk, they want to communicate, and they'll try. So that's where the paralexia comes in. So for like 99% of all patients, you'll find paralexia along with anomia. So I mean, like what this tells us, and this is like what comes from this. All these language disorders usually tell us something. Um, because you have things that like similar meanings and similar forms here, like symphony for sympathy and his shoes or issues. The way that words are stored in the brain is that we link together words that have similar sounds and similar meanings. So if we think about how words are stored in the brain, like if we have like this entry for dog, uh, we would also say that, cat is similar to it and puppy is similar to it. And we'd say these are closely related words. But we would also say, similar sounding cog is similar to it and dot is similar to it. So for different reasons, these are how we think that words are stored in the brain, and we get this information from patients with language disorders based on how they retrieve words when they have problems retrieving words. So what triggers anomia? Brain damage or people born with the condition? It's usually brain damage. There's some damage somewhere in one of the language centers in the left hemisphere, either somewhere in the frontal lobe or somewhere in the temporal lobe. Uh, I don't know if someone can be born with anomia, because anomia is something that you it's hard to lose the ability to name things before you can even name anything to begin with. Like anomia has to be something that's usually acquired later in life, once you have already acquired a language. If you were born with anomia, it'd be a little bit hard to diagnose. It would probably be misattributed to something else because you'd have troubles acquiring language. And you'd probably call it like a specific language impairment or some other language impairment. This is a really interesting case too. I forgot this was on the slides, but this was um, anomia is sometimes temporary. There is a case by an actual psychologist. Um, just a blood flow issue in the brain resulted in anomia for 45 minutes. So a psychologist was just working. There was no blood flow, just in one area of the brain. And for 45 minutes, he was unable to use words from his everyday professional vocabulary. He knew what everything meant. He could talk totally normally, but he just could not access certain words. So there's a little link there if you want to know the little brain map of where this is caused. But yeah, little story there. So this can happen. This can happen. More commonly caused by diseases or physical trauma. I mean, it depends. Most of it's blood flow issue, like stroke. If the brain doesn't get enough blood to a certain area, or if there's too much blood flow and a blood vessel pops, then it can cause brain damage. So that can be caused by physical trauma. That can also be caused by other issues, any sort of disease, any sort of medication that's taken improperly. I don't know the exact stats on that, so I can't answer that question. But there are many different ways that blood flow can. There are many different ways that can cause problematic issues in your brain and can cause blood vessels to burst or you to not get enough blood into certain areas. Okay, that's all we really have for anomia. The brain is a very scary thing sometimes. You can be totally fine one day and then you can just wake up and just have problems. And it's so hard to diagnose. Like you have to really press your doctors too when you have issues. Trust yourself. Be very forward with doctors. That's an aside thing. That's an aside thing. But anyways, let's let's try not to make this a scary lecture. Let's talk about dyslexia now. Dyslexia. So dyslexia are problems with reading. And normally when we think about dyslexia, like just casual dyslexia talk, we just say dyslexia. Oh, that person's dyslexic. But there are many different types of dyslexia. There are two main types of dyslexia, and then there's some other types. So we'll talk about the two main types. We'll talk about how we read aloud, and then we'll talk about a few more. So these are the main two that are on your third assignment question. And it doesn't seem like there's much here, but there's a lot that we can actually get out of this. So the main two are phonological dyslexia and surface dyslexia. So phonological dyslexia, what it says here is that patients show good performance with real words, but poor performance with nonsense words. So what phonological dyslexia does is it basically says that patients are not good at looking at words and figuring out how the letters correspond to sounds. So they're not good at taking a word piece by piece and understanding reading conventions. So bad at the rules of reading, but good at retrieving words from their mental dictionary or mental lexicon. So this is how we can summarize phonological dyslexia. So when they look at nonsense words, these are words they have never seen before. So they don't have any clues in their head about what it means or how it's pronounced. So when they look at those words, they cannot read them, they struggle with them. But if they look at words they've seen before, like interception, they don't have to read it piece by piece. So they can just look at interception and they can go access their mental dictionary and say, oh, I've seen that word before. I know how it's pronounced. I know what it means. So I don't need to look at it piece by piece. I can just look at the whole word and I can read it. So if you have phonological dyslexia, you have trouble looking at it piece by piece, but you can just see the whole word and you're okay with it. So phonological dyslexics have issue with new things because they have to look at it piece by piece. Surface dyslexics are sort of the opposite. So with surface dyslexics, okay, so what it says here is patients are good at reading aloud words that are regularly spelled, including nonsense words. So they're really good at normal reading rules or spelling rules, but they're not good with irregular spellings. So what this means is that they're bad at retrieving words from their mental lexicon, but really good at the normal rules of reading. I can summarize this concisely. So, surface dyslexics, when they look at the word at a whole, they can't go into their brain and say, okay, I've seen this word before, how do I pronounce it? Instead, they have to look at it piece by piece and pronounce the word as it's written. So if they see interception, they might go inter, then they look at the CEP, and that might be a little bit tough for them because the C is normally pronounced as a K, but it's pronounced as an S there. So with interception, they might go interception. They might have a little bit of difficulties there. So they can't access their mental dictionary. So when we say dyslexia there, you can think of it as what they struggle with. So phonological dyslexia, they struggle with the phonology, reading piece by piece, and surface dyslexia struggles with looking at the word at a whole and going into their brains and accessing the spelling or accessing the pronunciation. So before we move on and talk about the roots for reading aloud, are there any questions about these two types of dyslexics? Is there one more common than the other? Sorry.
I have a question.
Yes.
Um, so for the first one, phonological dyslexia, are they, because like they're retrieving words from their mental lexicon, are they able to learn new words then? Like, because like it is memorized, but yeah. So are they, because like, let's just say they have a new word that, let's just say interception, right?
Yeah.
They're unable to break it down, I suppose, in a phrase, in a way. Uh, like, but then someone teaches them, I guess, like, oh, this is how you say interception, right? Like, are they able to keep that, and then in the future they can retrieve that from their mental lexicon, or is the hindrance like hinders them from learning it effectively or at all?
Oh, they can definitely learn it. It's just that the more they read it, they will see improvements, but they'll still struggle with it over time.
Okay.
Yeah, it's just as like they'll when they look at the word and they read it piece by piece, they'll struggle. But as soon as they recognize the word as a whole, they'll start to improve and do better.
Okay.
Yeah.
Okay, that
Again,
makes sense.
yeah, dyslexia is just a reading issue. It's not an acquisition issue. Is there one more common than the other? I'm not quite sure about that, but typically you see issues with phonological dyslexia more often than you see it with surface dyslexia, at least through observation. But I don't know with diagnoses whether or not one is more common than the other. But through observation, I typically see phonological dyslexia more. Does the frequency of these types change depending on the writing system of a language? That's a really good question, and I'm not sure. I've only ever seen these in the context of like English, French, Italian with like the Roman alphabet. So I don't actually know. I know nothing about dyslexia in terms of like other writing systems. That's a really interesting question. Which is interesting because I know someone who is Mandarin and has dyslexia. who reads and writes in Mandarin all the time and has dyslexia. I should really talk to her more about it. Um, Yeah, I'm gonna go ask it.
Okay, so I did a quick Google, and I think what might be a possibility is like really similar characters. So like if you have we have Ren and Rue, right? Like the difference between person and, well, the other character is deep, but I can't explain that. But the characters are very similar to each other.
Mhm.
Um, so differentiating and just reading the characters might be a little difficult for them. That might be for dyslexia in Chinese. And yeah.
Yeah, yeah. I think in some cases with like the logograms and pictograms, that there is this very subtle difference between dyslexia and also just character recognition. I mean, like how do you I guess it's like when do you know that someone's fully acquired it in the learning stages? I guess when you're an adult versus when you're a kid. Um, yeah, I mean, there's definitely dyslexia in 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 Chinese. Like for sure there's dyslexia. And I think I know what the character for deep is. Yeah. Yeah. I mean for sure it exists. Yeah, dyslexia is just to do with reading. So when someone reads Deb instead of bed, and someone reads Deb instead of bed. Yeah. Saying the dyslexia isn't about saying, it's just about reading. It's just about reading. So we'll talk about that a little bit more in a bit. Uh, let's just talk about the dual route to reading aloud first. Okay. So, what we get from these two types of dyslexia is that when we read aloud, we're not just employing like one strategy. Uh, like when we read, when you first start reading or when you look at a new word, you normally look at the word in chunks. Like you're looking at different syllables, different combinations of consonants and vowels, like in or for to get information, and you go back and forth to see how it's pronounced. You're also taking a look at the letters to see how you think it should be pronounced. But then as you read a word more often, you just look at the entire word as a piece and then you move on. So we say there's a dual route to reading aloud. There's this grapheme to phoneme conversion. So this is the character to sound conversion. So let's use a different color. I'll just short this. This is character to sound conversion. So these are the rules that we have in our system. So like for instance, the EA is pronounced as E in each or T, and the PH is pronounced as F in photo or graph. These are just rules. So these are rules that we learn when we're kids in elementary school and middle school, or just we learn on our own as we start reading books and hearing people pronouncing them. That's one strategy we use. The second is this whole word reading where we access our mental dictionary or lexicon. Um, and this is information that's specific to words. So when we have words with irregular spellings or pronunciations, so when we see a word like steak, we see EA here, and we know that it's not steak. Steak rhymes with cake, even though it's EA there, and EA is typically pronounced as E, but in this case, it makes an A sound. This isn't a phoneme rule, a grapheme to phoneme rule. This is just a whole word mental dictionary entry. Or love. Uh, this is an interesting case. OVE. This rhymes with of, even though according to all these other rules, where like, um, move. MOVE is ooh, but LOVE is of. Shouldn't this be Louvre or Lobe? No, it's love. Why is it love? Well, this is just like a mental dictionary entry. There's no real rule that we're following here. And then if we say, well, what about dove? How are we storing this one in our brain? Well, are we going to pattern it with move or are we going to pattern it with love? Well, in our minds, we're saying, okay, dove. Dove is a lot more similar to love than move. So in our brain, we're taking dove and we're putting it with love. Like that's how we're introducing it into our brain. And this is more abstract, of course. Like I'm just trying to make this seem like a real thing, but in our brains, it's happening very differently. Um, But these are two different strategies we use to store words and to read words. And this is why it's called the dual root model to reading aloud. So we use both of these strategies at the same time, and depending on which type of dyslexia you have, you're really limited. So if you have phonological dyslexia, you don't really have access to that first strategy. You can't do grapheme to phoneme conversion. You only have whole word reading. While if you have surface dyslexia, you don't have access to whole word reading. You just have grapheme to phoneme conversion. No, this is for everybody. So everybody uses these two. So everybody uses 1 and 2, but if you just have phonological dyslexia, then you only have 2. If you have surface dyslexia, you only have 1. So like when you have dyslexia, you're limited in your strategy that you can use. But everybody can use both of those if you don't have dyslexia. So this is what dyslexia is telling us, is that when you have dyslexia, you're becoming more limited. You're losing access to one of your roots. And this is actually a little bit more simplified than it should be. Because actually, these two roots are a little bit more expansive. Because with the whole word approach, there's an assumption that we're actually listening to what we're reading to and that we're paying attention. But when we read whole words, we don't actually have to pay attention to what we're reading. And similarly, when we look at words and we read them piece by piece, we're not always reading sounds. Sometimes we're just reading letters. So there's not really 2 paths. There's actually 4 paths. So let's talk about each of these. We can call these 1A. Sorry, I'm not going to number these because the numbers are a little bit different than the order on the previous slide. The first path is whole word to semantic interpretation to phonological output. So whole word means we get a word like cost, and we read the word cost. And then what we do is we interpret it. So in our minds, we know this is money. Our heads say, okay, we read the word. We know we're interpreting this as money. And then when we read it out loud, we say, okay, that's cost. That's a pronunciation. We read it out loud. Okay. So we use this path when we actually want to understand what we're reading or when we're doing something difficult. Because this bit right here, this is like, this is our understanding. We actually want to understand what we're reading out loud. Usually when we read out loud, we don't do this. Like you can think of the time when you're in high school or like in public school and you're in a classroom and your teacher like goes from person to person reading out loud. When it's your turn to read out loud, you're not retaining anything of that. You're not retaining any of that information. You're just speaking. You don't have time to think about what you're saying because you're too focused on reading. What you're actually doing in that case is the second thing. You look at the word like cost, you're not actually thinking about what the word is. All you're doing is speaking it out loud. You're just saying cost, cost. And this is when you don't actually have to understand anything. So when you read books to children or when you read to other people, this is normally the path you take. So this is a lot less mentally taxing. So this is like the whole word track. The other two are grapheme to phoneme conversion. So when you want to learn new words or read new words, you do the grapheme to phoneme conversion. So if you have a word like, let's use a different word, like say you word like a trapping. So you would go like tra, and then you'd have another syllable like ping. So you'd read it syllable by syllable, trapping, trapping, and you'd try to learn it piece by piece until you understand it. So you'll be learning that new word there. But not always when we see a new word do we read it phoneme by phoneme or syllable by syllable. Sometimes we see just a code or a password or something like KLB47, something like that. We don't read this as a syllable. We don't read this as a word. We just read it letter by letter. So this is letter by letter reading. And this is something where it doesn't have any meaning associated with it. It's just something to memorize. There's no content here. So just quite literally KLB47. So although there's two main paths that sort of are the dual root model, we can really break those two strategies down into four different purposes. Reading to understand, reading to just speak out loud, reading to acquire new words, and then reading just for pure memorization. Okay, are there any questions about these? Okay. Let's talk about a few more types of dyslexia, and these are a lot more rare than the others. So deep dyslexia. This is a lot like phonological dyslexia, but these patients have a lot more issues. So this is a lot more rare. So we don't really see too many patients with these. But these patients have just an incredible amount of difficulties reading. So they can't really sound words out, and they make visual errors. So they'll read words and they'll substitute them out for words that look the same. So visual errors, so like love instead of live, or hoppy instead of happy. So hoppy instead of happy is another example. They'll make what are called semantic errors. So words that are similar in meaning. So in other words, instead of reading the word dog, they might instead of read the word puppy, or they might even read the word kitten. So even though the word is written dog, they may still read the word kitten. So they're making semantic errors. So they see dog, but their brain is saying kitten is a very closely related word to that. So we're going to read the word kitten. So this is why it's called deep dyslexia. It's a deep disorder. Derivational errors. So this is more about the form of the word and the root of the word. So a word like go, for example, has many different forms. Go, try to do some different color. Going, gone, went. Some children might say goad, but you wouldn't find adults that say goad. So a derivation error, someone might read go as any of those different forms. So instead of saying go, they might say going or went. And finally, function errors, any of those function words like the, in, but, on, and, some, many, any function words like that, they might just substitute those with another function word. So anything that's not a noun, adjective, adverb, or verb, they might just make any sort of substitution. So someone with deep dyslexia is making a lot of errors, and they can be quite varied, but they'll always fall into one of these four categories outside of phonological errors. So that's one type of dyslexia that you can also find out there. There are two more types, and these are even more rare than deep dyslexia, but they're actually kind of interesting. I've never heard of these other types before actually seeking these out, um, because I've heard there are many types of dyslexia, so I wanted to include some other ones called neglect dyslexia and attentional dyslexia. So neglect dyslexia happens when you have right hemispheric brain damage. So this is interesting because uh, the language is in the left hemisphere, but this happens after right hemispheric brain damage. So uh, patients cannot see the final letters of words, and it doesn't matter how the word is shaped. So whether the word is forwards, backwards, upside down, no matter what, like they just cannot see the final letters. So the word here that they give is allow. And no matter how it's shaped, they can just see the word all. So they cannot see the OW in allow. So this is neglect dyslexia. In other words, they're neglecting the final letters of the word. It's a really interesting reading dyslexia. It's something I've never heard of before, but that is something that exists with patients. I didn't know that was something that could happen. It's just their visual field does not see letters. Attentional dyslexia is interesting too. So if they see something in their visual field and they just see a word like dog, they're fine. They can see dog. If they have another screen and they see the word cat, they can read the word cat. But if they have a screen and they see the word dog and cat on the same screen, suddenly they have difficulties reading. And this is called attentional dyslexia. So essentially, because there's so much stuff going on in their visual field, it requires too much attention. Therefore, they then have difficulties reading. So difficulties with reading comes up because there's too much attention required, or too much attention, too many attentional resources required. Maybe that's the better way to put it. Okay, so those are the 5 different types of dyslexia that we'll talk about. These last two, there's not too much to talk about them, but I just thought they were very interesting because they're not really ever talked about. Any questions about dyslexia before we move on? Okay, so we're just going to talk about Broca's aphasia and Wernicke's aphasia, and then we'll finish up. So there's not that much left. We don't need to take a break because it'll be like 7 or 8 minutes. Okay, so we're going to talk about sentence structures now. That's all with words. Now we're going to talk about issues with sentences. So we'll talk about Broca's aphasia and Wernicke's aphasia. So Broca's aphasia, issues with sentence structure, grammar. Wernicke's aphasia is issues with word storage, word retrieval, language comprehension. So there's some information about particularly where this occurs in the brain. Here's like a little picture of where this happens. So speech production is in the frontal lobe. That's Broca's area right there. It's a little wider area. Wernicke's area is in the temporal lobe. That's for language comprehension. And if you're wondering where dyslexia happens, this is in the angular gyrus. So right above Wernicke's area. Okay, so Broca's aphasia. What does this look like? Well, Broca's aphasia issues with sentence structure, enters with grammar. So what you see with Broca's aphasia is a lot like what you see with early children. You don't find very many function words, and you don't find very many grammatical markers. So words like the, in, on, but, and, although, however, you don't find like past tense, present tense, you don't find ing, all these different things. You will not find them in Broca's or patients with Broca's aphasia. So we call this agrammatic speech. Agrammatic, a meaning not or not having. So it lacks a grammar. So um, patients with Broca's aphasia, when you listen to them speak, it does not sound very good. It sounds, of course, it doesn't have a grammar to it, but they can understand what you're saying as long as you speak with simple sentences. And they can access all of their content words. So if you say a complicated word like justification, however complicated you might think that word is, they know what it means. They just cannot string those words into complicated sentences, and they cannot use those words like prepositions or articles. So I don't have an example here, but we'll see an example in a bit. But the sentences are usually quite choppy. There's a lot of pauses and a lot of words that are missing. Wernicke's aphasia is a little bit different. So when you encounter someone with Wernicke's aphasia, the sentences sound great. They sound grammatical. But when you listen to what they actually say, it doesn't make much sense. So they say things in a very roundabout manner. So instead of picking concise words or language, because they have difficulties finding words that are concise, they'll say things in a different way. So instead of saying "I slept on my bed," they might say "I slept on the box that's in my room that people normally sleep on." So they'll find another way to say it. We have these things called neologisms. So these are words that just don't exist. So all of those accidental gaps in English, they'll just make words up and they'll put them in sentences. How they'll do that quite a bit. And what's really, really interesting about these patients, and something quite amazing, is that they can produce sentences and they will not understand or even be aware of what they've said. So they have ideas in their head and they're producing the ideas that are in their head and they're saying those ideas and they're not making much sense because they can't find the words for them. But they don't know what they've said. They're not aware that they've spoken their ideas. And they're also not very good at understanding what other people have said because people with Wernicke's aphasia, this is the loss of semantic ability. So this is the loss of meaning. So although they can hear themselves speak, they don't understand what they're saying because they can't interpret what they're saying. So this is a very interesting disorder. I'm very like I've never encountered this in real life. Um, it's weird saying this is one of the things that I'd like to encounter in real life because of course I don't want to encounter it. People who live with this disorder I don't know how they live with this disorder. It's incredibly frustrating. If you listen to people talk about this and their experiences, of course they have help when people talk about this. They say it's incredibly frustrating and difficult to live with this. Um, but I imagine, well, it'd be interesting to experience and actually be in the presence of someone who has this to understand what it's like. If you ask someone to repeat something they just said, would they have trouble doing that? Absolutely. If you ask someone to repeat something they just said, they would probably be unable to because they wouldn't know what they said. and they might not actually understand what you're asking them to do. Would they have problems with writing it down instead of saying it aloud? They would have difficulties writing it down too. The problem with aphasia isn't necessarily a writing or speaking thing on its own. It's an access thing. It's a language access issue. So they can't access the words in their head. So whether they're speaking or writing, they're having difficulties accessing those words. So they'll have a little bit more time when they're writing it down. So people can recover from this. So they can recover from this. So after they've recovered from Wernicke's aphasia, yeah, they might be able to talk about this. So I mean, that's how you could talk with someone about it. But in the moment, it would be difficult to have a conversation. Would their inner dialogue be coherent then? I'm not sure. I'm not sure about that. You'd have to ask someone who had Wernicke's aphasia at the time, if how their inner dialogue was. Inner dialogue is a question that I haven't actually seen asked in an interview or in a write-up about it. Maybe mentioned as an offhand comment that I didn't pick up on, but that's another interesting question. Another problem with like these aphasic studies is that when you have patients that have these language disorders, when personal experiences are reported, patients do have to agree to having those their data and their experiences published, and that doesn't happen all too often. So usually there are case studies in that manner, and there aren't a lot of very recent case studies on this. Usually it's just data, experimental data across a few participants with anonymous experimental findings and no personal experiences reported. That's usually how it goes. Okay, so here, let's take a look at these two. You can probably take a look and guess which one is from a Broca's aphasic patient and which one is a Wernicke's aphasic patient. That's not really the goal of the question, but you can guess which one's which. The goal more is to look at these two samples and really take a look at, why the one on the left is Broca's and why the one on the right is Wernicke's. So the one on the left, this is Broca's. So we don't have, we have syntactic issue. We do have some grammar. Well, I don't know, but it's right. Okay, so we have a little bit of grammar here, but for the most part, candy, cookie, candy, slam, early, fall, men, many, no, girl, dishes, soap, soap, water, water, falling, paw, that's all, dish, that's all. So not much is being said here. There's not really any grammatical words, there's just content words. Thoughts are struggle. It's a bit of a struggle to get thoughts out. It sounds as if this person cannot speak the language. And it's unfortunate. So how do you think when people hear this person speak, how do you think that people in real life are going to respond to this individual? People probably aren't going to talk to this individual like a normal person. But if we think back to Broca's aphasia and the consequences, this person can understand simple sentences in English just fine, even though the production isn't good. Even though many grammatical words are missing, even though there's no complex sentence structure, people with Broca's aphasia can understand simple sentences in English. But if you hear that, the way that you treat them is probably not going to be, normal. Um, just based on how people are. Compared to the person on the right, which is an example of Wernicke's aphasia. First of all, this is falling down just about, and it's going to fall down, and they're both getting something to eat. But the trouble is, this is going to let go, and they're both going to fall down. I can't see well enough, but I believe that either she or will have some food, and that's not good for you. And she's going to get some for her too, and that you get it there because you shouldn't go up there and get it unless you tell them that they could have it. So when I said that, I sounded grammatical. Everything I said flowed very nicely, but nothing made sense. And that's something that people with Wernicke's aphasia can do. Everything sounds perfect, but nothing makes sense. Things are repeated, the vocabulary, nothing is very concise. And you can imagine that if you hear someone talk like this, you could speak to them and you would think they could understand you. But the reality is, with Wernicke's aphasia, this person probably can't understand what you're saying to them. So again, like I'm trying to make something a little bit more real here for you. And this, it's always a touchy subject, but this is the reality. When you think about people with language disorders or any sort of disability in the real world, you imagine these two people, one person with Broca's aphasia, one person with Wernicke's aphasia. They get into trouble and they're talked to by someone like in the police force or a security officer. Um, you know, who's going to be talked to regularly? And, you know, one of them is going to be expected to understand what the officer is saying. The person with Wernicke's aphasia, that person is going to be expected to understand exactly what is being said. They're probably going to be assumed to be drunk or something. But the reality is, even though that person is saying things that are completely grammatical, uh, they don't make sense and they cannot understand simple sentences because they've lost their ability to understand meaning. The person does not even understand what they're saying. They're not drunk, they're completely fine. But they just don't have the language ability to understand things. But because they speak grammatically, there's this assumption that they can understand what we're saying. So they're more likely to run into problematic circumstances in real life than someone with Broca's aphasia. Broca's aphasia, they can't speak grammatically, but actually they can understand things just fine, and they can respond to commands, to behaviors. They're a little bit more functioning in terms of semantics and understanding and meaning. So it's sort of an unfortunate consequence of reality. So just so you're aware, these language disorders in real life. This is what you could encounter at some point. Jay, are there any questions about Broca's aphasia or Wernicke's aphasia before we talk about the very last thing, and then we'll be done? Okay. The last part. So, the overall assumption about language is that it is independent from everything else in the brain. So, attention, memory, and so on. But there are some interactions, and of course, like you can only understand as much as you can keep in your mind with memory. and the real world, other things you've experienced are going to have some influence. That's the general idea of how language works in the brain. Um, so one more disorder called specific language impairment is an acquisition disorder. And about 7.6% of all children have SLI. And this just means that children acquire language a little bit more slowly than other children. I say a little bit more slowly, but it can also be a lot more slowly, depending on how severe it is. And out of those 7.6%, about 80% continue to have problems into adulthood if they're not intervened at a young age. So it's only language issues. They don't have any other issues. They don't have motor skill issues. They don't have intelligence issues. It's just language issues. And you can fix this by having children do role-playing activities, vocabulary activities, language immersion activities at a young age with other kids with these problems. If you compare this to something like autism or Down syndrome or other types of early development disorders, that number is usually about 1% of kids. So SLI is around 7.6%. It's a lot more common than you would probably ever think it is. So what's that, about 1 in 14 kids or something? Okay, so that's why we think language is independent from everything else in the brain, because kids with SLI don't have any other impairments. It's just language. And there's usually two types of SLI. There's what's called receptive or expressive development language disorder. So this is when children don't have any grammatical features and have difficulties producing like complex consonants. So like, for instance, they can't produce like the PL or the past tense D in played. So instead of saying played, they might just say pay, because the PL is too hard, and the past tense ED is something that they can't do because it's grammatical. And also the vocabulary. They don't have a big vocabulary, so dogs might be too specific. So instead, they would just say animal. They might also have what's called, this is called just expressive developmental language disorder instead of receptive expressive developmental language disorder. And this is just when speech is delayed. So this is just speech delay. At what age is it clear that it's not normal speech development? So this is around 4 to 5 years old. If you're around 4 to 5 years old and your kid is still saying things like I pay animal or I pay with dog instead of I play with dogs, then there's probably some sort of language development disorder with your child. And it can still be fixed. So your child is not a lost cause. It can still be fixed. You can take your child to a speech pathologist in school. Might be a special little class for your child to do more role playing or language immersion activities, vocabulary immersion activities. Is there a cutoff age for helping fix it? There's not a cutoff age, but the earlier the better. Again, you want to get your child exposed to language as much in that critical period. So before the age of 7 is that critical period. Once you get past that critical period, language acquisition is much, much tougher. So before the age of 7 is always going to be better, because that's when we think that critical period for language is. That's when children are best at acquiring language. So if you diagnose around 4 to 5 years old, you have a couple of years to work at it. And they can catch up. So that 80% that still have it at adults, that's 80%, that's 80% with no intervention. 80% retain it with no intervention at all. So 20% will recover, just without any help. With help, that number is going to decrease drastically. With help, there will be a lot more recovery. Okay, so that's it. If you really like the neurolinguistic stuff, SFU does have a language and brain lab. It's called the Lab. They do mostly phonetics experiments, but they do exist. They have an ERP machine where they hook electrodes up to the brain. We'll talk about that a little bit next week. We also have a certificate in speech science. So if you want to become a speech language pathologist and work with brain stuff and language stuff, there's a path to do that. And you can also become a speech language pathologist. Um, if you are interested in linguistics, that's a path that many Ling majors take. Ling majors usually go into 3 different paths or 4 different paths. Speech language pathologist, uh, English teacher across the world, graduate student, and then computational linguistics. That's one of 4 paths that most linguistics students take. The 5th one is job market for other things. I don't know what they do, but that's usually one of the 4 paths. If you're wondering what's a speech language pathologist, well, they do lots of different things, lots of different disorders. Maybe not some of the stuff that we did today, but they help people with aphasia. They help people with swallowing disorders and speech disorders, both kids and adults. Um, so uh, a lot of different things they can do. They're paid not the best in the world. They're not going to be paid as nicely as a doctor or an actuary, but they're paid quite generously. Um, I think it's somewhere between like 80 and 150,000, depending on how much they do. So, yeah, that's it as far as neurolinguistics goes. The practice exercise this week isn't that big because there wasn't that much content. Um, but with that, you should be able to finish the assignment number 2. Uh, I'm going to stop the recording now, but if there's any questions about assignment 2, you're free to stick around and ask them. But otherwise, you're free to go, and I'll see you next week. So for everyone who's leaving, enjoy the rest of your week, and I'll see you next week. I just said next week like 6 times in a row. I need a bigger vocabulary. See ya.